by Dr. Nivedita Mondal. The session will be chaired by Dr. J.K. Reddy. I call upon the chairperson and the speaker.
So we have Dr. Nivedita Mondal from GDBPCON, who's been working on the follow-up of preterms and high-risk babies. So today we have a holistic approach to high-risk infant follow-up. I think practically also it is very useful for us, and for the PGs also it will be an important topic, the exam too. So hope we'll have a good time.
A very good afternoon to everyone here. My sincere thanks to IAP for inviting me to this forum. So in the next 20 minutes or so, I'll be talking to you about a holistic approach to the high-risk infant follow-up. Now, throughout the session, I will not go into the intricacies of the process. I will rather touch upon the basics and suggest some more holistic and wholesome ways of doing the same. Now, over the last 1 decade, follow-up programs of high-risk infants have been pushed into the forefront. Owing to the improved survival of smaller and sicker babies, it is becoming imperative to understand the burden of neuro disabilities in these babies. Now, another reason why the high-risk infant follow-up programs are gaining popularity is because now we have understood the strength of early intervention. And early intervention can only be instituted if you have kept your baby under follow-up and detected problems early enough, preferably even before the parent has noted it and complained to you about it. Now, at the very least, any newborn follow-up program would want to follow up its very low birth weight infants, those less than 32 weeks, those babies who have suffered from perinatal asphyxia stage 2 and 3, and those who underwent exchange transfusion due to hyperbilirubinemia. But the remaining risk factors mentioned here make an infant at high risk for adverse neurodevelopmental outcome as well. It is really up to you to choose and customize your inclusion criteria for the follow-up program, depending upon how much patient load you're willing to see and what kind of resources you have. So the schedule for the newborn follow-up is not carved in stone. It is rather flexible. Most of us would want to follow up our newborns more closely till they reach term-corrected age and then space out the visits 3 or 4 monthly for the first year and then have a visit at 18 to 24 months. You can also synchronize these visits with the immunization visits as is suggested by the facility-based newborn care module. But there are programs in the West which actually recommend very few visits. The bottom line is that you need to have enough number of visits in early infancy to detect problems of growth early, and you need to have sufficient number of visits in later infancy to detect problems of neurodevelopment early. Now, it is not at all necessary that every visit has to be at your center. You could ask the parents to come to you for a few visits and give them the convenience of performing the remaining visits at a local health facility which is closer to their home. The duration of the newborn follow-up at the very least is 18 to 24 months. This is the bare minimum. But problems of attention and behavior often come to light after the second decade. And if you could push your follow-up till 5 years, that is really good. And if you could extend it till 8 years, that is excellent, because then you could look at the academic performance of your high-risk infant as well. Now, these are the components of a very basic newborn follow-up program. You look at the general aspects, you do the screening investigations, and you do the neurodevelopmental assessment. So you start by knowing the gestational age of your baby because you need to use the corrected age for a preterm till 2 years. You plot your growth, you track your immunization, and you address the medical problems. When it comes to screening investigations, right on top is the retinopathy of prematurity screening. Now, the ROP screening guidelines are pretty established in your country. All the authorities agree that a baby who is less than 2 kgs and less than 34 weeks deserves an ROP screening. And very importantly, if the neonatologist thinks that this baby is at a high risk for ROP, then even if the baby is more mature and heavier, you have to refer the baby for an ROP screening. So the timing of screening is again very clear, 4 weeks. And if your baby is an extreme preterm, you have to do the screening a little earlier. This is a very well-known fact. But what is not very well known is that even if your baby has finished the ROP screening, the NICU graduate is at a high risk for developing other problems of vision like amblyopia, strabismus, cerebral vision impairment, and therefore it is mandatory to do an ophthalmological examination between 9 to 12 months and again at 3 years. The hearing screening for a high-risk infant is slightly different from that of a low-risk one. In the later, autoacoustic emission is good enough, but for the former, you need to do an automated ABR. That is because OE cannot detect auditory neuropathy. So the first screening ABR It's done once your baby is 34 weeks mature, at the end of 24 hours, and certainly before discharge. If your baby has failed the first screening, do a second screening maximum by 6 weeks. That again is AAPR, not OAE. By 3 months, you finish your evaluation and you do your intervention by 6 months. So the 1-3-6 rule of newborn hearing screening applies to high-risk infants as well. This is very well known to us. Now again, a lesser known fact is that even if your newborn has passed the newborn hearing screening, the audiological evaluation or the audiological follow-up is not over. Many of them will continue to be at a high risk for ongoing hearing loss and will require another evaluation, usually at 9 months, in spite of passing the newborn hearing screening. I completely recommend reading this position paper, which states the indications where, in spite of passing the newborn hearing screening, the baby requires an audiological evaluation later in infancy. Now, the ultrasound cranium screening for all very low birth weight, at the minimum do one between 1 to 2 weeks, and again at term corrected age. But if you are endowed with better resources, I recommend having a more comprehensive screening program starting on day 1 of life for the extreme preterm. This protocol, which was published in Indian Pediatrics a few years ago, is a very good one. Now, the thyroid screening for a low risk infant can be done either with TSH or free T4. But when it comes to the high risk infant, a combination of the two is recommended. The timing of screening, however, remains the same. It is 40 to 72 hours. If your baby was less than 32 weeks mature at birth, then it is prudent to repeat a screening after 2 to 4 weeks. Now let's move on to the neurodevelopmental assessment. The first aspect is the neurological examination. This is to be done diligently at every visit. At the very least, do a structured neurological examination. But what is preferred is to use a standardized tool, a validated tool for neurological assessment. This paper, again, a must read. I completely recommend each one of you here to read this paper. Very beautifully presents how the two tools of Prechter's general movements and Hammersmith infant neurological examination helps you to predict cerebral palsy. Prechter's general movements, 98% sensitive in predicting cerebral palsy at 18 to 24 months. And the Hein, which is the Hammersmith infant neurological examination, nearly 90% sensitive in predicting cerebral palsy. So this gives you the evidence of why you should not just do a general neuro examination, but rather spend some time in learning one of these two tools. Now, the Prechter's general movements requires certification, and the course is not particularly cheap. It is also not particularly easy to carry out the general movements assessment. So I would completely recommend going for the Hein. So the Hammersmith infant neurological examination is easy to learn, very easy to administer. It is validated between 2 to 24 months of corrected age. It gives the result in the form of a number, a score, which is easy to explain to the parent and also can be tracked over time. The Hein training modules until recently were freely available online. Unfortunately, the website is now asking you to pay and register for it, but I really think it's worth the money. Now, developmental assessment of a high-risk infant can get as holistic as this. This one was proposed by the American Academy of Pediatrics. My heart completely sinks every time I look at it, so we'll not look at it. I'll suggest a more holistic yet desi style of doing a developmental assessment. So instead of doing is developmental surveillance, which Dr. Srinivas Raghavan was mentioning, just ask the mother milestones. Instead of doing that, please use a validated, standardized developmental screening tool at every visit. Now, if you cannot get yourself to do even that, then use a screening tool at least at the 3 touch points, 9 months, once between 12 to 18 months, and again between 24 to 30 months. So Dr. Srinivas very eloquently explained the various screening tools available to us. Choose yours. The twin sisters, Trivandrum Developmental Screening Chart and Language Evaluation Scale Trivandrum are good enough. But my personal favorite here is the Ages and Stages questionnaire. So Dr. Srinivas was mentioning that it is paid. It is true that you are supposed to buy the manual, but unofficially let me tell you that the tool is freely available over the internet. Anyone can download it. It takes no time to learn the ASQ. And the best part about ASQ is that it gives you the development of the child in 5 different domains. So that helps me to explain to the mother that look, this and this are the places where your child is lacking. And it helps me to tailor my intervention as well. So when it comes to developmental assessment, a detailed evaluation is recommended at least once between 18 to 24 months of corrected age, and ideally whenever your baby has failed the developmental screening assessment. So the 2 tools commonly used are Developmental Assessment Scale for Indian Infants DASI and the Bailey Scale for Infant Development, BSID. Now, both tools are not free. You need to get trained and certified. The kits cost money, and they are quite time-taking. So let me tell you something here. You don't need a DASI or a BSID score to refer your child for early intervention. If you simply do a developmental screening with a standardized tool very diligently, religiously at every visit, you will be able to pick up those babies who are at a high risk for poor outcomes and refer them to early intervention. So if you do not have a clinical psychologist who is able to administer these tools, don't fret. Just go ahead, choose a good developmental screening tool and run your program. It will still run very successfully. Now, do not forget the autism screening once at 18 months and again between 24 to 30 months. Again, a host of tools are available. The MChat is very popular. Most of us use it. It's a complete free download. Go to the website, download the material, read up, and you will become an expert in no time. Now, if you are planning to run your follow-up beyond 2 years of age, in that case, you will have to arm yourself up with these tools. You need to know how to do a formal IQ assessment, school readiness, and childhood behavior too. So those were the components of a basic newborn follow-up program. Now, in case you want to make your program more holistic, then you need to add 3 more items to it. Activities of daily living, psychosocial environment and parental health, and a system in place to ensure that your parents keep coming back to you. So 42% of the preterms have problems with eating later in childhood. There are several tools which are standardized for assessing feeding behaviors in children. You really don't have to use any of those tools, but simply ask a few questions at every follow-up visit. Ask the mother what is the variety of food that your child eats. What is the consistency? Is the mother still putting the food in the mixie and making a puree out of it for a 2-year-old? So does your child have a problem with eating? Just simply asking a few questions will give you an idea if the child is actually having a problem with eating. Similarly, sleep time, duration of sleep, screen time, duration of screen time, and level of toilet training are equally important. Now, when it comes to screening the home environment, again, there are several tools which can be used to do the same. But again, if you cannot use those tools, that is perfectly fine, but do not miss asking a few questions so that you get some idea about the kind of environment that your baby is growing in. So simply ask the parents a few questions. Are you stressed out? Do you sleep well? Do you play with your child? Does anyone else in the family help you with caregiving activities? Simple questions like these would help you to get an insight about the kind of environment that your child is growing in. It is practically impossible for any human being to remember all these points at every visit. So I completely recommend getting checklists in place. We use these in JIPMA. You can use checklists which already exist, or you can simply make one for yourself. Now, coming to the intervention. So at the very basic, a newborn follow-up program has to offer medical care and early intervention. But if you want to make your program more holistic, you need to add parental guidance as an integral part of your early intervention. The parents need guidance about 3 things: activities of daily living, they need guidance about childhood behavior, and very importantly, they need guidance to understand the importance of follow-up. If you tell your mother that she needs to come back to you every 3 monthly for the first year, she may not be even able to understand why she needs to do so, especially because when the parents see that the child is apparently growing normally, they feel that there is no need to go back to the doctor. So you need to do a good amount of counseling here to make them understand that there are problems which may not be detectable by the parent, and it will really help if it is detected by the doctor early, because there are ways of treating those problems. Now, one-to-one counseling for every parent in the OPD is practically impossible. So please fall back on posters, get some PDFs ready, have some printed material, make videos, and use those to do your parental counseling. Now let's move on to early intervention. So there is no one here who would not understand the importance of early intervention. You either link yourself up with the DEIC, or you somehow constitute this team. So this team looks extensive. These are the number of therapists that are needed to run a follow-up program. So let me tell you a little secret here. I find special educators a very useful species of therapists. Special educators know early intervention. They are good at early language development so they can develop as a speech language pathologist, and they also know a bit of oromotor so that they can do the work of an occupational therapist as well. So if you are planning to run your newborn follow-up program for just 18 to 24 months, and you do not have the kind of resources to employ this entire list of people, employ a special educator and a physiotherapist. The two people will be enough to run your show for 18 to 24 months worth of follow-up. But if you're planning to go beyond 24 months, then you will need this entire team. Now, whenever a doctor makes a diagnosis, the same doctor writes the treatment. But when it comes to children with disabilities, it is unique in the sense that the doctor makes the diagnosis, but the treatment, which is the therapy, is given by someone else. And it is not just the doctor doesn't even know what the therapy or the treatment that is being given, the doctor often doesn't even know who the therapist is. So conventionally, follow-up programs have been running in this manner, where there is a medical team, which is unofficially headed by the neonatologist or the pediatrician, and the referral is always one way towards the therapy team, which doesn't have a leader at all. It is high time that this model changes into a model where both the medical team and the therapy team work together. They are a single team. They are not two separate teams. Communication has to be bidirectional, and it is up to us pediatricians to make the first move. We have to take the initiative, take up the role of being the coordinator. We need not call ourselves the leaders. We are the coordinators, and get the medical team and the therapist team to talk to each other. Now, world over, high-risk follow-up programs have shown dismal compliance. Even the New England network was able to show a compliance of only 52% at 18 to 24 months. Studies from India show even poorer compliance. You need to have a system in place to make sure that your mother brings the child back to you for 1.5 years to 2 years. So simple measures like writing the date of appointment on the first page of the discharge summary instead of the last one, because parents do not flip through the discharge summary and go to the last page. Writing the appointment in the local language, this helps. If you can make reminder phone calls or send text messages and WhatsApp, that is really good. But for those parents who are not able to come back to you, please consider using teleconsultation. COVID taught us the strength of teleconsultation, and there is no better area in pediatrics to use teleconsultation than to use it in a newborn follow-up program. And finally, if you want to know where you're headed to, you need to track a few quality measures. Now, as soon as I talk about quality measures, the question is, who does the data collection? That's $1 million question. Who does the data collection? Data collection always sounds difficult. Whatever it is, have an Excel in place or make a Google form, whatever it is, but try to collect data for at least 1 or 2 key performance indicators. So I have mentioned a few indicators here. The proportion of infants who have come back for a visit at 18 to 24 months, this proportion of infants who finished the ROP screening, those who finished the hearing screening, and those who enrolled in early intervention. It is up to you to choose your quality parameters, but whatever it is, put in some effort and collect data and see which way you're headed to over a period of 2 to 3 years. Finally, these are the 10 steps to get a holistic high-risk infant follow-up going. First and foremost, keep pushing the age limit of follow-up upwards. Every year, keep pushing it. Secondly, remember that ophthalmological follow-up does not end with vascularization of the ROP. Ophthalmological follow-up extends beyond ROP screening. Likewise, audiological follow-up does not end with passing the newborn hearing screening. Use a standardized tool for neurological assessment. Use a standardized tool for development assessment. Assess activities of daily living. Never forget the family. Assess the psychosocial environment of your child. Consider parental guidance to be an integral part of early intervention. Give importance to parental guidance. Impress upon them the need for continued follow-up. Respect your therapist and consider them to be your comrades. Make them part of your team. And finally, track quality indicators. Thank you.
Thank you, Nivedita. That's what last 10 years experience you had put in 10 minutes. A few points which you had told was really good. I feel that we all must know that once we are discharging a child from the NICU, as the newborns are becoming more preterms and more NICU stays, we must always tell the parents, as you said, that there is a follow-up to be done. All of us, we think that we are done with the baby coming out of the NICU and we are in success. That is not the one what she says. Please always prepare the ground, prepare the parents as doctor was saying, the child needs to follow up. So suddenly you tell sometime your baby needs an eye checkup or vision or hearing, then the parents are little worried what the doctor is what is going to be the results. We prepare them the early, the better it is, and even to referrer also, they will themselves will go if we prepare them early. If not, most of the time when we ask them to go, they will tell we'll wait for 2 more months, we'll wait for 3 more months, and which again will have a problem. And other important point, always in our practice for last 20-30 years, I'm telling, the one which we don't examine, that fellow only will have the developmental delay. So keep in mind, please examine everyone, and the one which you don't examine, that is the guy. All the PGs I said, if you are not looking for this, then that fellow will have that. So keep in mind. And the last is medico-legally we are all responsible. We are very much there for the patients. If tomorrow max marks comes 99, they will come and ask you what was the APGAR score, what was the developmental assessment at 9 months. So these are things no parents are coming and asking us. Please, all of you must remember, everything must be on paper. As doctor was saying, you must have a checklist which must be in the file, and parents must know that we are following.
Thank you, Dr. Nivedita Mondal, for that passionate talk on approach to high-risk infant follow-up, and the chairperson for consolidating the talk.